But how do we know what happens next? Well, here's the problem. Don't take those questions just anywhere. I always say this and I always will. Don't just ask the right questions. Make sure you're asking the right question to the right person. Your doctor is number one in all of this. You have to trust your team. You have your family behind you, or friends, or hopefully a support staff that you can lean on, because this is ugly, right? It's a bad thing to go through physically and mentally. And I'll tell you, the mental part of this is just bizarre, and we're going to talk about that. All right. This is HCRD.online. It's still humor, culture, and real discussions, but sometimes it's personal, where I bring you into my story, unfiltered, and inviting you into the parts that most people hide. This is HCRD.online, and this is the beginning of something real. Hello, my friends. My name's Steve Niemeyer. This is HCRD.online. This is where you get to jump into my brain and run around and collect some pieces of information and jump out the other side, and you get to analyze it yourself. All right, that's just the way we're going to make things work around here. I have information I want to share with you. I had prostate cancer, had a prostatectomy August 28th of last year, and just completed 8 weeks of dual band radiation because it came back. And they said decipher score of 1, which is as bad as it can get. And with the aggressiveness of my cancer, you're going with an 8-9, and now you have a decipher score of 1. Bad things were going on. So we zapped that, and I am still doing hormone therapy, and I will be doing that for a while. I told the doctor I would do that for 6 months, and he said, Steve, you're not doing it for 6 months. You're going to be doing this for 2 years. And my wife says, so what's the difference between 6 months and 2 years if you do this? And I said, that's the problem. They have 6 month studies and they have 2 year studies, and they can compare those, but they're not the same people. So you can't put the two studies together to come up with, is it better and how much better? And with the radiation that I had and with all of this, what's the next step? This is why I keep saying with prostate cancer, the further you get into the journey, the more it isn't like everyone else's journey, right? We're on the same broad path of prostate cancer, but how we deal with that, it depends on the aggressiveness of the cancer, where it is it contained, how did you find it, how early, what's your Gleason score? All of these things come into play so you can get a better, bigger picture. Now, let me tell you something. They made a few mistakes when I was going through all of this. Number one, I did not have a PSMA PET scan before we did it. I had a bone scan. I don't know why we didn't do that, because I had one before I started my radiation/hormone therapy, because the doctor said we need to know if it's already escaped. And I said, okay, so here's the problem. We need to do a decipher score. And that's another mistake. Why didn't they do the decipher score when they did the biopsy? Because some people have the order completely wonky. And I know I'm going off the beaten path with this, and my notes will get to the basics here in a minute. But when you look at everybody's journey and you start looking at numbers and why didn't they do and what would have happened if, because they said you're a 3, blah, blah, whatever. It's a bad 3 going into this. Gleason, an 8. And they said, well, it's a 3, 5, 4, 5. And I said, so it's an 8, 9. And they go, it's crazy. Let's do the decipher test. Well, if they would have done it when they did the biopsy, we would have known that we were dealing with a very aggressive cancer. We would have known that it had already escaped. They said, well, we tested lymph nodes, and they were negative on the ones that we tested. And they don't want to take all of them just to test them, right? Because what happens when they remove those, you retain water and your legs get puffy and you're taking pills to try to get rid of all of that. It all plays into it, right? Your lymph nodes are there in your body everywhere. serving a purpose. And when the cancer goes there in your prostate bed or into the lymph nodes, and you said, well, you know what, Steve, here's the problem. Your PSA is jumping and we need to do something. And so instead of just the prostate bed, we did the prostate bed. We also did the lymph nodes, and started me at the same time doing the ADT, which is the hormone therapy deprivation. So you have zero testosterone, or at least they're trying to bottom that out. So that has all kinds of crazy side effects with it. And some people will never go there. Some people won't have that. And if I would have known, would I have done something different? What would I have done? I had to have surgery in my mind because I had a big mass. Your prostate is walnut size, and you go, well, how big is it? An English walnut? Is it one of them? Listen, walnut, and it's sitting right underneath your bladder, and the urethra goes through it so you can excrete waste, urine. All right. So the prostate itself, let's say it is the size of a walnut. I had a mass that was a third, again, of my prostate. So you just add another third, and it was all this big, crazy, cancerous mass that was ugly, and a Gleason 8-9 and a decipher of 1. So these are really, really, really crazy bad numbers for me, right? But how do we know what happens next? Well, here's the problem. Don't take those questions just anywhere. I always say this, and I always will. Don't just ask the right questions. Make sure you're asking the right question to the right person. Your doctor is number one in all of this. You have to trust your team. You have your family behind you, or friends, or hopefully a support staff that you can lean on, because this is ugly, right? It's a bad thing to go through, physically and mentally. And I'll tell you, the mental part of this is just bizarre, and we're going to talk about that. All right, I keep changing my mind on what I'm going to do here, because this is very important to me to get this information out. And if it's not from me, I hope and pray that it's from someone else, because this is scary stuff. And you have to have the friend, family, support staff behind you. Because like I said, things are going to get ugly. Emotionally, you're going to have baggage, and you need people to talk to, maybe not even to respond to you, but maybe to let you vent. And you go, well, that sounds like my wife. It could be the medicine. I don't know. Hormone therapy could make me have that attitude, but it's very emotional, the stuff that you're going through, and it makes your mind get all wonky and you forget stuff. And I'm hoping now things are going to get better on that aspect, where I have more energy. I stopped my radiation and then went back to 10-hour days. And then I'm also working for the radio station here locally. And I have a lot of stuff on my plate, but this is a passion of mine to help men understand what is going on with prostate cancer. If you want to live through this journey that I have experienced, you can go back and listen to that personal story. I will interject, because I always do because I agree or disagree with some of the stuff that I'm going to tell you. And we're just going to go through it. So 10 minutes in, this is the basics of what we're talking about with prostate cancer. What is prostate cancer? It is a type of cancer that occurs in the prostate. Duh. A small walnut-shaped gland in men that produces seminal fluid. It is one of the most common types of cancer in men. So what are the symptoms, you might ask? Early stage prostate cancer may not have any. I didn't have any. As it progresses, symptoms may include difficulty urinating, frequent urination, especially at night, weak or interrupted urine flow, pain or burning during urination, blood in the urine or semen, and pain in the lower back, hips, or pelvis. If you're getting pain in your lower back, hips, and pelvis, chances are that is a stage 4. It is metastasized through your pelvic floor and into your bones because it goes that direction, right? It's going to get in there. So the thing is, don't think that just because you're getting up more at night, or you go, oh, my interrupted flow, or I just have to go more often. Don't just assume that's old age. Don't assume that it's a natural occurrence, that it's going to happen. So I'm not going to worry about it. It's one of those little pieces of the puzzle that you need to keep in the back of your mind to make sure that you stay healthy. So, how is prostate cancer diagnosed? And this is where a lot of people have it wrong. A lot of people are scared. A lot of people don't understand where the prostate is and what it does. So we went through where it is. We know what it does. And so prostate cancer is diagnosed through a combination of things. And we've talked about all of these, right? The PSA, prostate specific antigen blood test. It's a blood draw. And if you do not have that as part of your annual visit to the doctor, guys, and you go, well, I don't actually go every year. I go every 2 years, every 3. I never get sick. I'm telling you what, this is so stinking important. You need to know what your cholesterol is and your glucose and all of the things that you check, because your doctor's checking those, right? When you do the blood work. And if you're not going in once a year, come on. It is a half hour of your time, an hour of your time. I don't care if it's a whole day. It is so stinking important to be that advocate for your health and make sure you are doing whatever you can to stay healthy and stay away from this crap. So it is diagnosed partially through that PSA blood test. They have a DRE, and they make it sound like, hey, it's a DRE. What is that? It's a digital rectal exam. And you go, digital rectal, they're going to put something in. Yes, the urologist or your general practitioner or the guy next door, if that's who you trust, is going to do a digital rectal exam. That is with a digit. They are trying to reach in and they feel your prostate, and they're looking for any abnormalities, anything bulges, anything wrong. If it's the wrong, oh, that's really hard. That's really, it's big. It's what they're looking for, all of these things, right? Because your PSA can be elevated because you have an enlarged prostate. That is part of it, right? Sexual activity, bunch of exercise, all of those things that can make your PSA rise. But what you're looking for, my friends, is a baseline. You want to be able to chart it. Hey, it's 0.8. It's 0.9. Hey, it stays 0.9 for 5 years and it goes to or 1.3. And you go, oh, I need to watch this. And the next 2-3 years, it doesn't change too much. Well, you're probably pretty good, right? But if you notice that goes, hey, it went to 1.3 and don't worry, we're going to watch it. And the next year you go back and it's 1.9. And you go, doc, what are we doing? He goes, well, we can do a DRE. We can, try to figure out what's going on. Everything okay? You don't have any blood in your urine, nothing like that, right? No symptoms? Well, doc, if it's really early, we're not. Anyhow, so the next year, all of a sudden it goes to 3.1. And he goes, oh, no. And then it goes to 4.8. And, sooner or later, somebody's got to go, boom, and stop it. Now, another thing they kind of screwed up on me, I had to change doctors, and the urologist that I went to that I have now saved my life because he asked more questions than the other guy. Goes, you know what? We're not going to worry about it. You're getting older, and, your PSA is going to go up. And I went, okay, because I didn't know. Mine was 8.8, and it continued to go up. By the time I had surgery, it was 10 plus. That's their guesstimation. So they do that. And then you have imaging tests. And the next thing that would happen in the correct order is a CT scan. And the CT scan, they're going to look at it and go, ooh, we see that your prostate's a little enlarged, blah, blah, blah. And then we're going to do an MRI. And the MRI, they're going to say, oh, you have and they're going to categorize everything, right? What kind of lesion do you have? What grade is it? And they'll go through all of that and explain it to you. We do that or I rather have done that in previous episodes. Like I said, you can always back up if you need to. All right. So then the MRI, and the MRI is the big one, because you need to have that MRI before they send you to the next step, which is a biopsy. Because if they go, whoa, your prostate, you have a PIRAD 5 lesion that is big. It is, 2 centimeters by, and I go, I have a what? And they go, yes, this is a big mass. And when they were doing my biopsy, because you do the MRI, sorry, I want to make sure you understand why the order is important. The MRI is done because when you do the biopsy, they're not just going to randomly stab needles into your prostate and go, hey, we got, 14 cores or 18, whatever, however many cores they take. The MRI, they put you down there and then they go, hey, and they line you up. All right. And they go, hey, what are we doing here? No, I'm just kidding. It's not an ultrasound, but they're lining you up with that MRI. So what they see is what's there. And then they do the biopsy. And this is where a lot of people want to check out. Okay, it's bad enough that, you're going through all of this stuff. Humility is, here we go. You're going to go into a room, and I have read online, some people are sedated during this process. Some people are medicated during this process just to calm the nerves a little bit and realize what's going on. I, on the other hand, when I went in to have mine, they said, okay, Mr. Niemeyer, I need you to lay down facing the wall, and, you're in your little gown thing, right? And they're moving you around. I had my phone with me, and it was a lifesaver, not a lightsaber, none of that. It was a lifesaver because I was in there, and he said, do you realize, Mr. Niemeyer, that this is a teaching hospital, and you think it would be all right if we had a few students come in and watch this procedure? I'm thinking, what are we doing? I already have 5 people in the room, and I know what they're going to do next. I look back and I stopped counting at 5, and they kept going. You hear their little Skechers or whatever they're wearing, and they stop. And I go, oh Lord. And he goes, all right, now what we're going to do, Steve, and they lubricate a piece of equipment and they insert it into your anus. Now, what this is going to be is that helping line up everything thing. And it's also where they thread the tubed needle through so it can go in, and they stick it into your prostate in a specific location, and they go, and they pull this core out, and they do different regions of your prostate. And there's a couple different ways they can do that. They can do the probe type of way, right, where they have to insert that in, or they can actually cut and do surgery through that way. So they're not actually going through. People say you could get an infection doing that. Talk to your doctor when it comes to having the biopsy. But all of these people were in there. And now back to the lightsaber. It was crazy. I was like very uncomfortable, and they do this numbing stuff, and they said, well, there's nothing we can really do until we get a needle in there, and it's going to hurt, but we're going to deaden your prostate a little bit to make the cores a little easier. But then they turn the phone on, Spotify. Guess what? It is Cross Canadian Ragweed, and I was all right. And the guy that was doing this, after he injected me with his little Novocaine, whatever he was giving me, he says, what is that noise? And he thought it was like one of the kids behind him went, that's my ringtone. I didn't think about them, because this is all crazy embarrassing, and it lasts for a long time. But I said, that's me. I'm distracting myself. And he goes, hey, that's a good idea. And so I kicked it up a notch, and I get through this. And it's one of those things that's like this rubber band snapping, and you go, but you can't move through any of it, because you're lined up, right? Remember, we talked about all that. So anyhow, they took my cores and they do this and they said, now you can try to clean up. And you're cleaning up, right? And the guy that was standing there on the screen that was making sure I was all lined up and everything, and he goes, I am so sorry. And I'm all, well, what do you mean? What are you sorry for? Oh, that I just had to go through that and all those people were in the room. Gotcha. Until I got the results. And then I realized that big PIRAD 5 lesion that I had hanging off the side of my prostate was actually in my prostate as well. There was 90 some odd percent cancer spread throughout this. It was ugly. So we did that. So when you say, what are the treatments? Because now we have some answers. All right. We've done the MRI guided biopsy and we've targeted the cores the best of our ability, and we take those and we send them off to the lab and it comes back and you'll have your score. It'll be, hey, you know what? You are a Gleason 6. Okay. You go, you're a 7, you're an 8, you're a 7. Is that a 3 plus 4 or a 4 plus 3? And when they start doing the pluses and pluses, it's the first number is whatever the most prevalent level of cancer is. They're looking at this and they go, in these 6 cores that we were in that quadrant, and out of those, these were rated this and this. So there are more 3s and 4s, but 4 is the next greatest, so it's a 3-4. Or if 4, well, now you're getting into where it's scary, because anything 4-3 or above, and I think even a 3-4, you better be paying attention to what's going on. So they're going to do all of this. And then you're going to meet with everybody you need to meet with. And in this case, it is the oncologists that are going to happen. You have radiation, you have surgery. But like I said, I had already decided with this big, huge thing, I wanted it out of me, knowing that if something happened on the backside, I would be able to go in, do radiation. It would be a cleaner thing. I wouldn't have to worry about residual PSA or is this new PSA. Get rid of it. And so I did. Had some bizarre complications on the backside, not directly related to the surgery itself, but when they pulled that breathing tube out, I aspirated stomach acid into my lungs. I had aspiration pneumonia. I was in ICU and went home. I ended up with 2 really big abscesses in my stomach, and I had to have 2 different ports put in. It was a crazy deal, right? And then to find out afterwards, I'm undetectable for 2 tests. And then all of a sudden, oh no, it's not undetectable. Oh wait, it doubled. Uh-oh, it more than doubled. And so as we were looking at this, and even the 2-week, it was doubling in that 2-week time frame. And I said, guys, we need to do something. Well, this is when he did the Decipher test, right? Because he wanted to know what the heck was going on. So the Decipher said, yeah, it's a 1, which is aggressive. If we would have known that from the, see what I mean? I would have done radiation, boom, right after surgery, because they said, well, it was outside the margins. Yeah, very aggressive outside the margin prostate cancer. Good for me, right? So when I mentioned a 3-3 or a 6, even 3-4, some people say, hey, you know what? Or a 4-3, depending on your age and where you're at and what you decide to do with your doctor's advice. Obviously not mine, right? I'm just here trying to help get some of this info to you so you can make an informed decision. Remember, not only asking the right questions, but asking the right questions to the right people. So the active surveillance, I'm sorry, that's the 3-3, 3-4 is probably in that range or not, but a 3-3, usually they will suggest an active surveillance, closely monitoring the cancer without immediate treatment. Options often used for low-risk, slow-growing prostate cancers. Regular checkups, PSA tests, and biopsies help track the cancer's progress. Talked to a guy, had multiple biopsies before they figured out what was going on. And they go, found it. And I said, did you have an MRI? I did before the last one. And I said, what are you doing? So these things anger me, people. And so that passion, if I start going, why did they do that? It's because I care about what they're doing to you. So, I talked about the fact I had a prostatectomy. What is it? It's a surgical removal of your prostate gland, used for localized prostate cancer, or in my case, big, huge, nasty things hanging off the side. Get rid of it. It can be done through traditional surgery, and they used to do this, and it wasn't that long ago. They'd slice your entire belly open, and a lot of people died either on the table or from infections on the backside of that. Now it's a minimally invasive technique, robotic assisted surgery, which is why you've seen them do that on TV, right? Where they're able to make way microscopic slices, and just it's a nano slice. I like it. So anyhow, you can do that and you get rid of it, right? Prostate's gone. Your PSA should eventually be undetectable, and by that, an ultra sensitive PSA of 0.002, right? You need to be undetectable, and it depends on what lab it is and where they send, and all of that. But make sure it's an ultra sensitive on the backside of that. Radiation therapy is another option, and I'll tell you, I went through that one as well. Uses high energy rays to kill cancer cells, used for after surgery or as an alternative to the surgery, especially for patients who are not candidates for surgery. If you've had other operations and there's scar tissue and there's things they can't get to, or it's abnormal, or it's like really, really large, they may have to treat it with something before they actually can remove it surgically. So the radiation is an option. So the hormone therapy, it aims to lower levels of testosterone. We talked about this, that hormone that fuels the growth of prostate cancer cells. They say that all evidence is pointing to the fact that if the testosterone is what is feeding the cancer cells in the prostate. So prostate cancer, testosterone, drop it. And that's what the hormone therapy will do. If it's used either alone, sometimes, like I said, to shrink the tumor itself, if they can before they do another option, or it can be in combination with other treatments for advanced cancers. So that's where they would do the radiation along with the hormone therapy. Okay. And that's what I did on a follow-up. So got to do all three. Aren't I a lucky guy? Can prostate cancer be prevented? That's the big question. No, not really. No guaranteed way to prevent that anyway, but lifestyle changes, it can reduce those risks. But what happens is it's not today or last week or last year what you were eating. It's what you were eating in your 20s. And it's what you've done to your body with that and processed foods and all of that. Because healthy diets, maintaining a healthy weight, staying active, and avoiding excessive alcohol and tobacco use. All right. If you can, just stop smoking. Alcohol, moderation. But I'm telling you, this is one of those things where they say the Mediterranean diet is really, really good. Prostate cancer diet. But it also says that, hey, it does. No, stop. It helps if you do it today, but it's kind of like planting a tree. The best times was yesterday. Today would be, yeah. Okay. But you just go backwards. It would have been better if you would have planted that tree 20 years ago, right? So side effects of the treatments, we need to get there because I looked up and realized we're going to go long today. Side effects vary depending on the treatment. Okay, they can include erectile dysfunction, urinary incontinence, fatigue, pain, changes in bowel function. Some treatments also have emotional and psychological effects. Welcome to it. So what is the survival rate of prostate cancer? We need to get to that one, right? Well, prostate cancer generally has a high survival rate, especially if it was diagnosed early. The 5-year relative survival rate for localized prostate cancer is nearly 100%. Okay, so for most cases, 100% in 5 years. For advanced stages, survival rates decrease, but many treatments can still improve life expectancy. All right. So the long-term outlook after prostate cancer, it depends on the stage of cancer, the type of treatment that you choose, the patient's overall health. So depending on what you're doing, many men with prostate cancer live long and healthy lives, especially when the cancer is detected early and treated effectively. And how do we do that? How do we catch it early? PSA. Just the PSA. That's what you need to do. That's what I'm telling you. So the PSA, it's a blood test yearly. Get it done. The problem is, you want a baseline. Tell them you're not too young to get a PSA test. If you want it when you're 25 and you pay for it and you have a baseline and it's going to be low. But then when you're in your 30s and you have that and you go, well, why would I do it that early? Because it's a blood test. And there are people on the forms that say, I am 26 years old and I have stage 3 prostate cancer. There are people 32 years old, stage 4, metastasized. And I'm all, what is going on? So there's a lot of factors that are going to cause this to give you an elevated chance of developing prostate cancer. And people have said, well, if you live long enough, you're going to get prostate cancer. Prostate cancer, well, that's the good cancer. I've heard all of that, and I'm here to tell you, stay on top of it. The PSA, get it done. Make it a yearly thing. And if the doctor says no, have them call me and I will have a talk with them, because it's really, really ticking me off that the way some of the procedures are going, and not like a surgical procedure, but from point A to whatever you're going to do on the backside. So do not let a doctor tell you that it's too early to get your PSA checked, because it's not. You want a baseline. It's not that expensive. If insurance says I'm not going to cover it, that's fine. That is a great insurance policy, so you don't end up one of the 20, 30, 40-year-old somethings that end up with metastatic prostate cancer. And it's as simple as a blood test. This is Prostate Cancer Awareness Month. 2 weeks from now, I get to go on a prostate cancer walk with my daughter and my wife, and I think the whole family is going to get together and walk. And the thing is, I get to wear a survivor shirt or a participant in the journey, whatever they're going to put me in. I don't know. But it's a scary, scary thing to go through, my friends. And catching it early is key. And that's a PSA. And tell your doctor you want it done. Okay? Spread the word, my friends. Like us, love us. Get me anywhere and everywhere in front of your friends, especially this episode. And then if they want to go back and listen to the others, they can, because I'm here to get this crap stopped and make sure that when you're going through this, they're doing it in the correct order and you're getting the best advice. Remember, it's not only asking the right questions, it's asking the right questions to the right people. Until next week, you guys be good. You've been listening to HCRD.online, and we're just getting started. Subscribe, share this with someone who needs to hear it, and follow along as we talk more about what it really means to live through the tough stuff, with humor, culture, and real, unfiltered discussions. I'm Steve Niemeyer, and this is HCRD.online. We'll catch you next time. You guys be good.